Vrushali, please start. Unmute yourself and restart.
Good morning, everyone. Warm welcome to everyone for part that is Pediatrician Section for Teenagers Healthcare today. And we have two talks today, that is adolescent OCD and sports nutrition. And we have our esteemed Dr. Neeti Soni for our first talk in that is adolescent OCD. Dr. Neeti Soni, I'm going to introduce Dr. Neeti Soni now. Dr. Neeti Soni is the first adolescent expert in Marathwada region. She was in charge Marathwada region of AACCI, that is Association of Adolescents and Child Care India. Ma'am was the president and founder member of NGO Get Going Women for Fun, Fitness and Health. Ma'am has presented lots of papers in various national conferences regarding the same. Also written a chapter in IAP AHA textbook of adolescent. I request ma'am to please start on your talk, that is adolescent OCD.
Let me welcome Dr. Neeti Soni ma'am. She is adolescent pediatrician from Aurangabad, and also our second expert, Dr. Amok Shane ma'am from Navi Mumbai. She is also adolescent pediatrician and very great sport athlete, and also she does regular gym activities and inspire many of the teenagers, many of the pediatricians from nearby her area, and friends and family members also. So this pediatrician action plan for teenagers healthcare, this path was conceptualized by Dr. Atul Kanikar sir and Nasik AHA team, Dr. Sulba, Dr. Trupti, Dr. Sucheta Malhotkar madam, Dr. Surose sir, Dr. Reena Rathi, and many others. So this this was started in the year 2023 under the presidency of Dr. Ramakant Patil sir and myself as the secretary, and almost we have finished almost more than 18 to 20 sessions, and the adolescent experts from various parts of India, all the members of AHA Academy, they have came here, and now also they are joining. Dr. Preeti Galgali ma'am is there, and many others, they might have joined for this workshop, for this webinar, and they have came on Maharashtra IP platform, and they have deliberated on various different topics of adolescent healthcare. So these two topics are also very much important for the adolescent well-being. And in a short notice, just now in last week, we have finished our national first time in Nasik. We have conducted, we have been given, and we have conducted this AdolsCon 2024. And many of Dr. Neeti Soni was there, Dr. Amok ma'am was there, and many other AHA stalwarts and all other adolescent experts, some general pediatricians who were interested in knowing what is this Adolescent Health Academy, and what this scientific program was very well conceptualized by AHA team, and they have came here last week, and immediately within a short notice of 2 to 3 days, Dr. Neeti Soni ma'am and Dr. Amok ma'am, they accepted. We have already got one MMC point for this webinar, so we do not wanted to waste that 1 point and give the delegates, Maharashtra IP members, that 1 point by conducting this workshop. So thank you, Neeti ma'am and Amok ma'am, for accepting this request. And I also welcome all the experts, adolescent experts and delegates and PG students and general pediatricians, and some of the parents and teachers as well from Team Maharashtra IP. So now I request Neeti ma'am to start her talk straight away. Thank you one and all.
Thank you so much. Is my slide visible?
Yes, ma'am.
Make it full screen, ma'am.
Yeah. Is it full screen now?
Yes, audible, full screen, yes.
So good morning on this very pleasant first Sunday of October. With the ongoing Navratri and the late night Dandiya, I am so happy that so many of you all, 106 people of you all have joined. I would first like to thank Dr. Amol Pawar and Maharashtra Academy of Pediatrics with IIP Nasik as well as AHA Nasik for giving me this wonderful opportunity to present in front of the learned audience. I'd also like to thank Dr. Vrishali for the warm introduction. The topic I'm going to take today is adolescent OCD. So according to DSM-5, OCD is a disorder of thought wherein the person has uncontrollable, reoccurring thoughts, which are obsessions, and or behaviors, which are compulsions, that he or she feels the urge to repeat over and over again. It is chronic, long-lasting, debilitating, and frequently has its origin in childhood and adolescence. So, what is an obsession? Obsessions are one's own thoughts coming repetitively and is anxiety provoking and it is distressful. They're also ego dystonic, which means that the person having these thoughts, they do not want these thoughts, but it keeps on coming repetitively. The most common obsession that we hear day in and day out is the fear of contamination, and which we had seen rampantly during our COVID times. Similarly, compulsions are repetitive mental acts or physical acts which are performed to respond to an obsession. They are anxiety relieving, plus they are ego dystonic also. The most common physical compulsion is repetitive hand washing in response to the obsession of contamination. There are mental compulsions as well. For example, chanting verses to relieve the stress. So, 1 in 4 people in the world suffer from OCD. And in India, the prevalence is as high as 0.6% in the teen population. With our country being known as an adolescent country, this amounts to a very huge number. It has a bimodal onset. Excuse me. That is, the first peak is in the adolescence, and the second is around 30 years of age. The mean age of onset of OCD is 19.5 years, and 25% of the cases start by the age around 14 years. Onset after the age of 35 years is unusual. Males have an earlier age of onset as compared to the females, and nearly 25% of the males, they have the onset of OCD before the age of 10 years. The onset of the symptoms could be gradual. However, acute onset and even episodic onset have also been seen. Seen to the male is to female ratio, it is seen that 3 to 2 is to 1% of ratio is seen between the boys and the girls. Coming to the diagnostic criteria for OCD, presence of obsessions, compulsions, either obsessions or compulsions or both of them. The obsessions or the compulsions, they are time consuming. For example, they take almost around an hour per day. And of course, they do cause clinically significant distress or impairment in the social, in the occupational, and other important areas of functioning. The obsessive and the compulsive symptoms are not attributed to the physiological effect of a substance. Any drug or abuse or medication will not produce similar symptoms. No other medical condition will also be producing such symptoms. The disturbances are not better explained by symptoms of any other mental disorder. Example, excessive worries, generalized anxiety disorders, they also at times do present like OCDs, but they have to be ruled out before we label them as OCD. So there are lots of OCD themes seen in the adolescence, but there is no official classification of subtypes of OCD The DSM-5 TR and the research have suggested people experiencing OCD symptoms are usually around these 3-4 categories. First is the cleaning and contamination. Second is symmetry is compared to incompleteness and ordering. Third is harm, either to self or others, leading to shame and guilt. This is at times even categorized under taboo thoughts, and as such, taboo thoughts can be kept as a separate type also, where the person has thoughts of violence, religion, and sexual behaviors. Some people with OCD may also have obsessions and compulsions regarding hoarding or the need to keep on collecting things. This isn't all inclusive. It is possible to have obsessions that center around themes or fears. But coming to only the common ones and just trying to talk about it, the contamination OCD usually focuses on the persistent fear of being exposed to germs or toxins. Symptoms may involve persistent worry about the germs or sickness due to it. Then it could be the intrusive thought about feeling dirty or unclean, especially physically or mentally. Then there's an ongoing concern about exposure to the blood, the toxic substances, the viruses, and maybe the other sources of contamination. Compulsions for these may be intense avoidance of going to the places where such dirty things are seen. Such people will avoid going even to the hospitals, and they can be repetitive cleaning and washing rituals, scrubbing yourself continuously. Then the second type of theme was symmetry and ordering. Symmetry OCD may involve intense urge for items or belonging to be aligned in a particular fashion. There's an extreme need in these people. They feel everything should be in symmetry and everything should be organized. The need for symmetry, even in the body, the clothing, the actions, everything. If you scratch the left knee, you feel you need to scratch the right knee. The obsession is to that level. And in response to these obsessions, the compulsions would be repetitive efforts to arrange the belongings or the other items in a particular way, which they feel is just right. Then there's severe distress if they do not see that the things are aligned properly, kept symmetrically. Then they need to repeatedly do the counting rituals, such as counting a specific number of items in a number of times. Then the taboo thoughts are also OCDs, which may center around, they have different types, like scrupulosity OCD, which focuses on religious and the moral thoughts. In some instances, the people refer to this type of OCD as a single OCD. Here, they do not have associated compulsion. It's at times even known as pure OCD or pure form of OCD without a compulsion. Then there is a harm OCD, which centers around fear of harming others or yourself. Or it could also involve unwanted images of violence, of aggression. Then there is the next type is the sexual OCD, which may involve distressing thoughts and images or urges regarding sexual activity. Magical thinking around the fear, your thought that it can cause a natural disaster or an accident is again one type of fear OCD. All these will lead to guilt, shame, and other distresses about the obsession. There is a hoarding OCD. At times it is labeled as hoarding OCD. At times it is put under hoarding disorder. Here the person wants to keep on collecting things. They do not want to throw away things, feeling that they will be needing it at some or the other time later. This is seen in most of the females, I suppose, at home. But this is not an OCD what they do at home. This is something else. OCD, a hoarding type, is very difficult, and it is very difficult to tackle as well. So there is a higher rate of sexual and the religious obsessions in adolescents than in children. So there are also high rates of harm obsessions, example, fear of catastrophic events, such as a death in a family or a death of a loved one. This is more commonly seen in children and adolescents as compared to the adults. So coming to the OCD cycle, in this cycle, first the person gets an obsessive thought, which leads to a lot of anxiety. To allay this anxiety, this person will now start doing some or the other act to relieve that worry. And this is the compulsion. This compulsion does relieve the person of the anxiety, but it is very short lived, and the person again starts getting this obsessive thoughts. To give an example, if I start feeling that I am not good enough, and I start getting an anxiety about this thought that I am not good enough, then I will compulsively keep on doing more and more and more and more work so that I will prove it that I'm good enough. It will temporarily will give me a relief that okay, yes, I'm good enough, but that is again for a very short time. Again, for some in some time at some another event, the person again starts feeling no, I'm not good enough. So, what are the various risk factors to a person getting OCD? There are temperamental factors like those people who do a lot of internalizing of the symptoms, and those who have a lot of high negative emotionality and behavioral inhibition in the childhood. They are at a possible higher risk of temperamental reason for the increase in the risk. Then the next is the environmental factor, the physical and the sexual abuse in the childhood, and other stressful or the traumatic events which have been associated in the past can lead to an increase in the risk of developing OCD. There is a twofold increase in the first degree relatives with OCD, and there is a tenfold increase in the first degree relative who has had the onset of the OCD in their childhood. It has been observed that there is a dysfunction at the orbitofrontal cortex and the anterior cingulate cortex and the striatum. These are the more common areas of the brain which seem to be affected in a person having an OCD. So, what are the consequences of the person who has OCD and on the people surrounding them, the family? So, for the person, there is a reduced quality of life along with a high level of social and occupational impairment. There's avoidance of relationship with the family and the friends. There's delay in completion of the school or the home projects because the project never feels that it is just right. And this will lead to potentially lead to school failures. And if the person is doing a job, it can even lead to a loss of the job. Then individuals with contamination OCD, they have a fear of going even to the doctor's office because of the fear of getting exposed to the germ. They will avoid even after having problems. They will not go to the doctor, and because of repetitive hand washing, and the detergents used, they may develop some dermatological problems as well. The adolescents may avoid socializing with the peers, and as the adolescent turns into a young adult, and when it's the time for him to go and live independently, they have lots of problems because there has been a developmental delay because of the OCD. There are some individuals with OCD who will try to impose rules and prohibitions to the other family members. Especially like if the person with the OCD has a OCD of contamination, he will not allow any other visitors of any other family members to come and visit because it will lead to like he feels that the house will become dirty, and this will lead to family dysfunction. So, what are the differential diagnoses for OCD? Anxiety disorder, yes, it is the person with OCD has anxiety, but they have to be differentiated from anxiety disorders. In anxiety disorders, the thoughts are recurrent and that are present in like some real life concerns are there. Whereas in OCDs, they do not really involve the real life concerns. Then coming to the next differential is the generalized depressive disorders. The thoughts are usually mood congruent in generalized depressive disorders, and they are not necessarily experienced as intrusive or distressing. Then there can be disorders which very closely mimic like eating disorders, what we see as binge eating or anorexia. Here, there is obsession and compulsion are not limited, and there is no concern with the weight and the food. Whereas in eating disorders, the person is very much concerned about what the person is eating, how it will affect their weight. Then there are psychotic disorders like schizophrenia or schizoaffective disorders, where the person have lots of hallucination or they have formal thought disorders, and they also closely mimic OCDs. There are other obsessive compulsive like behaviors like paraphilias, gambling disorders, then alcohol use disorder. In this, the person usually derives a pleasure out of doing this activity. As compared to OCD, this will lead to anxiety. And the person with alcohol or gambling, they will derive not only pleasure and they will not do anything to stop it. In fact, they are happy and they want to continue it. As compared to what we discussed earlier, the person with OCD will not be liking these thoughts. So it has been found that OCD does not usually exist as a single entity. There are lots of other comorbidities and lots of other mental health disorders which are associated. Common amongst them is anxiety disorder, which is as common as the 76% of OCDs. They have anxiety disorders. Almost 63% have depressive or bipolar disorders. There are tic disorders seen in almost 30% of patients. Now, when there is a triad of OCD, tic disorder, and ADHD, it is commonly known as Tourette's disorder. And we had a movie with, I think, Rani Mukherjee showing this disorder as Tourette's disorder. Then there is an obsessive compulsive and the related disorder, such as body dysmorphic. They're never satisfied with the body structure. There is trichotillomania. There is a continuous pulling of the hair. Then there is excoriation type of a disorder, which is skin picking type. They are put under the heading of obsessive compulsive and related disorders, not OCD. This has been put in the DSM-5. Now, as already spoken, the schizophrenia and the schizoaffective disorders also are associated in almost 12% of the patients suffering from OCD. So, coming to the prognostic factors, it has been found that those patients who have had a childhood or an adolescent onset of OCD, they have a very poor prognosis. And almost 40 to 56% of individuals also have a severe type of OCD, but the severity may decrease, but the person continues to have OCD. Then there is another thing which is called as OCD specifiers. They are with the person having a good or a fair insight about their problem. So when with this specifier is added, then to the OCD diagnosis, it means that the healthcare professional has determined that you recognize your obsessions, that your obsessions are not probably true. And yes, they do cause distress. For example, you know that you won't get sick or die if you don't wash your hands every 10 minutes. So this is known as with a good or a fair insight. Then there is a poor insight. Here the patient feels that there are high chances that they will get sick if they do not wash their hands. So they are aware of their obsessions, but they're not very sure that this is going to be not true. Then there is an absent insight. Here the patient does not understand that this is an obsession and then this needs to be treated. So depending on these specifiers, a patient with poor insight about the accuracy of the problems have been shown to have a worse prognosis. And up to 30% of the individuals carry this disorder lifelong, and especially so if they're associated with tic. So coming to the treatment part of it, there are lots of tests to assess the OCD severity. And the commonly used test is the Yale-Brown's Obsessive Compulsive Scale. It has 54 common obsessions and compulsions grouped in. And there are also there are versions which are specially designed for children. They classify less than 25 as mild, 26 to 34 as moderate, and more than 35 as severe. So the pharmacotherapy is the most common thing used is the fluoxetine, SSRI, which can be used single or can be used in combination. To add to it, some people do use tricyclic antidepressant, and they are not as commonly used as the SSRIs because of its own side effects. Excuse me. And at times there is a combination of antidepressants along with antipsychotics and a low dose of clonazepam and lithium to add to all. Excuse me. Along with the medical management, there's also psychotherapy, which is in the form of cognitive behavior therapy, does play a good role in treating these patients. There is another therapy in the name of exposure response prevention. Here, for example, this patient is obsessed about contamination. So he's anxious, his anxiety keeps on increasing. Then he goes, he washes his hands, he feels better, anxiety decreases. And after some time, again, there is an obsession that everything is contaminated. So this is the way how a usual OCD cycle continues. But when we are giving exposure response prevention, here we do not allow the patient to give the response to the obsession. Like if the person feels that the hands are dirty and needs to wash, we will not allow the patient to go and wash their hands. On the contrary, we ask them to go and touch another dirty surface and prevent him from going and washing. This will again increase the anxiety. Gradually, the anxiety levels are kept on increasing. And by exposing them to a higher and a higher and a higher anxiety, the patient gradually gets habituated to it. And after multiple such attempts, the anxiety does not appear. This theoretically looks very nice way of treating it, but it is very challenging because the patient who has it, they are not motivated enough to take up this therapy. But at times, it needs to be given to patients who are diagnosed to have moderate to severe type of OCDs and always given along with medications. Those patients who are still not responding, who are resistant OCDs, they may need surgical interventions in the form of deep brain stimulation. And if still this does not work, then limbic leucotomy, which has been involving two processes, the anterior cingulus, which is the part of causing the OCD, there is a cingulotomy of that anterior cingulate gyrus, and along with it, even the subchordate tractotomy is done. With this, I come to the end of my talk. Thank you so much for your patient listening. Thank you.
Thank you. Thank you very much, Dr. Neeti ma'am. It was a very clear and precise talk on this topic. Thanks, sir. Thanks a lot, ma'am.
Thank you.
With this, I want. Is there any questions?
Yes. If anyone wants to ask any question, if anyone has query or anyone wants to add to it, please unmute yourself and tell.
If parents having OCD, there are any chances that...
Please introduce yourself and then speak, please. Yeah, your name and city name. Yes.
I am Dr. Nilesh Kodekar from Dombivli. If parents having OCD, there are any chances that means children get OCD, higher risk of OCD?
Yes, I have already mentioned that if the parent is suffering from the OCD, then there is a increased chance of the child having OCD. And also, what was the time of onset of the OCD in the parent, that also defines the occurrence of OCD. If the parent had an OCD in the childhood, then there is almost 10 times increased incidence of the child having an OCD. Dr. Nilesh, I hope I have been able to answer your query.
Yes, ma'am. One of the patient means parent having OCD, but they are not aware of OCD. And because of that, children getting OCD, but I'm unable to counsel them. I don't know how to counsel them. They are not ready to accept.
You can ask them to do the screening scale. There are lots of screening scale, and if the screening scale it shows OCD, definitely you'll be able to convince them.
Okay. Thank you.
Thank you.
Preeti madam want to add something, I think.
Yes.
Yes, ma'am.
Yeah, I'm Preeti
Ma'am,
Galgali
video
from
on.
Bangalore. Very nice presentation, Neeti. Congratulations. I
Thank you,
just
ma'am.
want to share a few cases. You know, we are so much worried about sexual abuse and aware about OCD as well. So we have children as as young as 5 years coming with sexual thoughts and making sexual figures, and we often think that this child is sexually abused. But after taking a thorough history, you realize that this child has not been sexually abused and OCD is the cause. And once they're put on fluoxetine, there is a remarkable improvement. And to the previous question, I would definitely say partner with the psychiatrist. That's really important when both the parent and the child you are suspecting OCD. I think partnership with a psychiatrist and psychologist will really help pediatricians to manage cases and also in counseling. Just two thoughts in my mind. I just thought I would share it with all of you.
Thank you so much, ma'am.
Thank you, ma'am. Thanks a lot.
Thank you.
I think there are no questions anymore now.
If there are any questions, it can be put in the chat box. We'll try to see if we can answer it later on also. And we have Preeti ma'am with us to give the expert comments as well.
With this, I welcome Dr. Amok Shahane ma'am for our second talk, that is sports nutrition today. Ma'am is director of Sanvi Children's Hospital, Kharghar, Navi Mumbai. She is also consultant at Sri Satya Sai Heart Hospital, Kharghar, Mumbai. Ma'am's major achievements are EB member Navi Mumbai IAP, treasurer AHA Navi Mumbai, youth forum in charge AACCI Navi Mumbai, SSS CIAP module Navi Mumbai coordinator. Ma'am has also published few papers nationally. Ma'am, I request you to please start session.
Thank you so much, Vrishali, for the kind introduction. Today, I'm really delighted to be on this platform because today I'm going to talk about something which is close to my heart, that is both sports fitness as well as adolescence. So I think it's like, an icing on the cake for me. And at the outset, I would like to thank MahaAP, Dr. Amol Pawar, Dr. Ram Gopal, and Dr. Atul Kanikar, obviously, for giving me this opportunity to be here today. So, are my slides visible?
Yes, ma'am. Please make it full screen.
Yeah. So, coming to today's talk on sports nutrition in teens, I would start with an overview of what we'll be discussing today. We'll be starting with introduction of why nutrition is so important in young athletes. We'll be seeing the total energy requirements, the macros, that is mainly carbohydrates, proteins, and fats they need to consume for very good performance. We'll be discussing about micros. We'll be definitely discussing about fluid requirement, which is very much essential for improving the performance. We'll be talking about recovery foods because usually recovery foods are not taken into consideration for athletes. We'll be talking extensively on meal planning, and definitely a gray area which I'm sure many of the fitness enthusiasts are aware of, that is supplements. So why nutrition is different for young athletes? Since we all know adolescence is already a period of rapid physical growth, optimum nutrition is of utmost importance for young athletes to attain proper growth and perform optimally in sports. So young athletes mainly need to learn what foods are good for energy, when to eat certain foods, how to eat during an event, and when and what to eat to replenish after an activity. So coming to the total energy requirements, sports nutrition enhances athletic performance by decreasing fatigue and the risk of disease and injury. It enables athletes to optimize training and to recover faster. So balancing energy intake with energy expenditure is crucial to prevent energy deficit or excess. So energy deficits, which we've seen, can cause short stature, can cause delayed puberty in athletes. It can cause menstrual dysfunction, loss of muscle mass, and increased susceptibility to fatigue as well as injury or illnesses. Energy excess, on the contrary, can result in overweight and obesity. So this I have taken from the National Institute of Health, which clearly mentions that before puberty, energy requirements are similar for both boys and girls. But as you can see in the chart, the energy requirements later on go on changing for adolescents, and they become variable depending on the age, the activity level, the growth rate, and the stage of physical maturity. And extra calories are needed during growth spurts and to replenish energy expended during athletic endeavors. For example, you can see in the chart between the age of 4 and 6 years in both males and females, around 1800 kilocalories are required per day, which goes up to almost 2000 kilocalories up to the age of 10 years. But after the age of 11 years, when there's a rapid growth spurt, energy requirements literally run up to 2500 per day for males and almost 3000 for males and a little bit lesser in females when they are active with their athletic sports. Then coming to macronutrients, we'll be seeing about the major important source of energy, and that is carbohydrates, which is the most important fuel source for athletes because they provide direct glucose for energy. Glucose is stored as muscle glycogen, which is the most readily available energy source for working muscle. So carbohydrates have to form at least 45 to 65% of the total calorie intake in children between the age of 4 to 18 years, which mainly consists of whole grains, vegetables, fruits, milk, and they should consume at least 3 to 12 grams per kg of body weight of carbohydrates daily. Protein, which are the building blocks for athletes, helps in repairing muscle, hair, skin, and nails. For mild exercise and for short duration, proteins are not a primary source of energy, but as exercise duration increases, proteins maintain blood glucose through liver gluconeogenesis, and they should form at least 10 to 30% of total calories in the diet. The timing of protein is very important when you consider an athlete because our bodies can only effectively use a given amount of protein at a time. So we have to evenly spread protein consumption throughout the day around 0.3 to 0.4 gram per kg per hour, which comes to around 15 to 25 grams protein per meal to maximum muscle protein synthesis. And the recommendation, as we all know in pediatrics, is at least 1.2 to 2 grams of protein per kg per day. So coming to dietary fats, they should form around 25 to 35% of total energy intake between the ages of 4 and 18 years. And saturated fat should not be more than 10% of the total energy intake. In that, obviously, we will focus more on the monounsaturated and the polyunsaturated fats, which are available in most of the vegetable oils. We will definitely encourage them to consume omega-3s and omega-6, which is usually found in non-vegetarian foods, and go less on the saturated and the trans fats. And the best sources of lean fats are mainly meat, poultry, fish, nuts, seeds, dairy products, and olive oil. One of the most important micronutrients to be considered for an athlete is iron, because the saying goes that supplements do not enhance performance. I'm talking about iron supplements here, but deficiencies do impede performance. And iron depletion is very common in athletes due to diets poor in meat, fish, poultry, and there's increased iron losses in urine, feces, sweat, and menstrual blood. So the recommendations are between the age of 9 to 13 years, around 8 milligram per day of iron. And adolescents between 14 to 18 years, in males, at least 11 milligram of iron per day should be consumed. And females, this is a little on higher side because of menstrual losses, which is 15 milligram per day. And the important sources of iron are eggs, green leafy vegetables, fortified whole grains, and meat. The important micronutrients along with iron to be considered for an athlete are calcium and vitamin D, which are available in many sources, right from milk and milk products, in broccoli, and in green leafy vegetables like spinach. The recommended intake of calcium between the age of 4 and 8 years is around 1000 milligram per day. And after that, up to the age of 18 years, minimum requirement is 1300 milligram per day. And vitamin D, the recommended intake should be around 600 international units per day. But we've seen that athletes who are more into indoor sports like gymnasts, figure skaters, and dancers, they definitely have a component of vitamin D deficiency. Coming to fluids, which is a very important aspect of optimum training, athletic performance can be affected by what, how much, and when an athlete drinks. environmental temperature, higher humidity affects dehydration, which can put athletes for alarming things like heat exhaustion and heat stroke. So for hydration, what we've seen before exercise, the guidance is to have around 14 to 22 ounces of fluid, which comes to around 300 to 500 ml of water before exercise. During exercise, it comes to around 6 to 12 ounces, which is around 150 to 200 ml of water or sports drink every 15 to 20 minutes of vigorous exercise. And after exercise, what has been found in studies is there is considerable amount of water loss, which sometimes is underestimated by the athletes. So approximately is for 1 kg of body weight which is lost, that is equivalent to around 1 liter of water lost. So we need to consume that much of water in the next 2 hours post exercise. For events which last for less than 1 hour, only water is sufficient. But for events which last for more than 1 hour, especially in hot, humid climates, sports drinks which contain around 6% of carbohydrates, that comes to around 25 to 30 grams of glucose, and around 20 to 25 milliequivalents of sodium chloride to replenish the electrolyte losses is definitely recommended. So these are the various formulations which are available in the market. We have these sports drinks, which are available in packs of around 500 ml to 1 liter. And I would like to definitely say over here that sports drinks and energy drinks are very different. Energy drinks, which we get over the counter, have high amounts of caffeine, which is definitely not recommended for any athlete or for any other person per se. And we also get readily available gels, which are around 100-gram gels, which contain both glucose as well as electrolytes. So after exercise, an important part of training is recovery, and that is through recovery foods, which should be consumed within 30 minutes of exercise, and again within 1 to 2 hours of exercise, to help reload muscles with glycogen and to allow for proper recovery. So they should be high in proteins and carbohydrates like a whole fruit, yogurt, banana, or peanut butter. So for an athlete to improve the performance, meal planning is of very much importance, which is quite tricky, but it has to be done in a very structured way. And there should be no experimentation with new foods or new routines on the day of competition. And the pre-game snacks, especially if there's an early morning game, it should be ingested 1 to 2 hours before the event. And after the event, a healthy breakfast can be consumed within 1 hour. And the pre-game snacks should contain fresh fruit, dry fruits, cereal with milk, or fruit-based smoothies. So coming to the most important part of sports nutrition, which I'm sure many of us have multiple questions, is how do we navigate all these supplements and all the marketing happening in the industry? So what I would like to say is, when considering supplements, remember that food should come first. Supplements, if used, should supplement and not replace a proper diet. If you can get your protein requirement in the diet through various food sources, definitely there is never a need for a supplementation. Supplements are not regulated by the FDA. There is no guarantee about safety, efficacy, or purity, and they may contain banned substances. So I would like to end with a very beautiful quote regarding to sports and nutrition, that the 5 S's of sports training are stamina, speed, strength, skill, and spirit. But the greatest of all of these is spirit, and I really wish the best of luck, and I'm sure we are going to give spirit to our youngsters to pursue their dreams. Thank you so much.
Thanks a lot, ma'am. It was amazing. It was really very precise, and almost all the questions you answered. Ma'am, I have one question to ask. Ma'am, regarding the carbohydrates, where the athletes or teenager athletes, they take for the fueling their performances, but how should they manage the weight? What are some practical strategies for incorporating the complex carb into their diet? Also fueling the performances, because they need to take more carbohydrates to fuel the performance.
That depends on the kind of training they are used to. Like mostly all the moderate and high intensity exercises and training, like, outdoor sports, they require more of at least 45 to 65% of carbohydrates. So like in the slides, I've explained the pre-exercise the day before and the morning before they go for the event, they have to load themselves with carbohydrates, but not too much of fiber because that can cause digestion problems. But it hasn't to be too heavy because it can cause a lot of bloating and indigestion. So they can go for complex carbohydrates like a fruit, a yogurt, or even milk with cereal, because these are broken down very slowly, because simple carbohydrates, they get broken down very fast, so the energy requirement is not fulfilled. So complex carbohydrates, they break down very slowly, so they can help in fueling through the entire workout or the exercise, which can last sometimes more than an hour or so.
Okay, thank you.
So there is a demand from Dr. Ashok Mehta, sir, Executive Board Member of National IIP, that Dr. Amok ma'am should take a session for fitness of doctors, mainly pediatricians. So ma'am
Sir,
will
actually,
consider
I would
that
like to
request.
share that Neeti Soni ma'am, surprisingly, we just spoke yesterday, and she is a fitness enthusiast herself. Neeti Soni madam also has done multiple half marathons. So I guess we are, on a very amazing platform here discussing nutrition and fitness.
And IIT gave us this opportunity to really know each other, like we share common passions as well.
So we ended up talking more about fitness than adolescence.
Yes, yes, yes. At this juncture, I would like to tell you that Dr. Amok ma'am has completed the marathon by means with wearing sari. This was unique achievement. So she has done.
Thank you, sir.
Ashok sir, any comments? Kindly unmute yourself. Pallavi ma'am, please unmute Ashok Mehta sir. Pallavi ma'am. Okay. Any other comment from any other? Vishali, any questions?
Ma'am, I have one more question.
Ashok Mehta sir is there.
Yeah,
Yeah, yes.
it was a nice talk. Both talks were very good. Amok madam, I've been following you on the Doctors and Fitness group, and I know your status and stature over there.
Thank you, sir. It's
And
always been a very supportive group, and I'm learning from everybody, including Neeti ma'am today. I've taken tips from her here only.
very good.
Sir, हमको भी add करो sir,
Mehta
Mehta sir,
is the
हमको भी add
manager of Mumbai Marathon, actually, Mr. Mandar Pandya. He is my brother-in-law, and I've been telling him to motivate people for that. But there should always be a session on fitness in all the doctors' conferences, because we have got a lot of food fads and a lot of bad habits, and how to go about it. There are many myths about the protein supplementation and gym. कि gym तो नहीं जाना चाहिए, छोड़ने के बाद मोटे हो जाते हैं. All these myths should be like किधर ना किधर उसको क्रैक करना होगा. So there should be a session. आपका अमोल अपना किसी कॉन्फ्रेंस में ले सकते हैं इसको.
Yes sir. We'll definitely include in Hyderabad Pedicon.
Sure. मैडम दोनों मैडम हैं और फिटनेस एंथुसियास्ट है तो होना ही चाहिए. You yourself are a sportsman.
एक 2 घंटे के लिए एक पैनल डिस्कशन और एक 2-3 टॉक रख देंगे 2 घंटे का.
Yes, like-minded people go
Followed
to
by
a hall and
push-ups.
discuss.
Followed by push-ups.
In the morning we can have a Hyderabad run also, marathon.
Yes, definitely.
So another fitness freak, Dr. Amruta Shirodkar ma'am is there. So ma'am has raised hand. So please.
Thank you, Dr. Amol. Excellent session, Amol. I'm sure she's like a fitness icon for all of us. I just wanted to add that now we have many adolescents who start resistance training quite early. And like Ashok Mehta sir already pointed out, they do ask us how to complete their protein requirement. And we also recommend them whey protein. But then sometimes the parents are very anxious to, itna jaldi de sakte hai and all. So I think that myth also needs to be busted, because I think always telling them that 1 scoop whey protein gives you almost 25 grams protein, and you require that if you are building muscles, you need that 1.5 to 2 gram protein per day. So I think that point, we should always, as adolescents especially, should impart to the parents, is what I feel. Other supplements, of course, are a no, which you rightly mentioned. So I just like to have your comment, and maybe even Preeti ma'am's or any seniors comment on this.
Actually, less than 18 years, officially we do not recommend protein supplements, because these kids are more into sports than into muscle building. They are more into endurance sports and outdoor sports. So more than protein, they need protein, but they need it through diet. And there are multiple sources of protein through the diet. Of just going through the literature, and if you, like how I said, if you incorporate 3 to 5 gram of protein in each meal in the Indian diet, definitely their protein requirement will be fulfilled. If a child
Right.
specifically wants to go for strength training or into bodybuilding, maybe after the age of 18, with supervision, they can take away a scoop, but then that also if there is no requirement in the diet. So we should be more of pro, pro completion of protein through natural sources, because nowadays what we've seen is many of them get a lot of false information from influencers. And as kids literally come with their parents and asking me ki I'm taking creatine, is it all right? And the parents are literally terrified ki what is happening, and sometimes this is happening and behind closed doors, when the parents themselves are not aware that creatine is being taken at this age. So we need to be totally against supplements, at least up to the age of 18. After that, definitely they have to weigh, take the pros and cons, and with proper professional guidance, then they can maybe take.
Yeah, I would agree with Amok. So there are a couple of papers which are very much there. I can share a couple of those. But the last word on whey protein has still not been said. I would say that. And there could be a time with the current research which is going on, because they are doing a lot of research in the adolescents and seeing, vis-a-vis taking the supplement and not taking the supplement. How does the sport performance vary? So the last word has not been said still, but for above 18 years. So, but keep a watch. I'm sure what the current is. Research is probably pointing towards that there may be a role. So we just have to keep our mind open as of now.
What is important is hydration also, because along with protein, there's a very big burden of it to be flushed out through the kidneys. So you need to hydrate, because that is not done properly by kids. They just keep taking supplements. But if your hydration is poor, then it is definitely going to compound the problem more.
And I would also recommend everybody, especially parents who are considering their adolescents into competitive sports, there are documents available both by the Indian government and the international government about international authorities about what are the banned substances. So even some things like even cough syrups, I'm just saying they could be actually, they may be a kind of a turning point in whether you are accepted for a sport or not. So there are documents available both at the Indian websites, sporting websites, and also the international. So again, I would strongly recommend that just Google, you'll get all the documents. You must go through those documents, what are accepted substances and what are banned substances. The WADA and the International Olympic Association, all of them are given very clear-cut guidelines.
Yes, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Anything to be added? Any questions, delegates?
I think, Vrishali, there was a question about menstrual irregularities in female athletes.
Yes, ma'am.
Yeah, actually, what I've just come up in the literature is initially it was called as female athlete triad, which I think many of us are aware of. But now the International Olympic Committee has now changed it to something called as REDS, which is relative energy deficiency in sports. And this is seen in a lot of female athletes, because what happens is these athletes, first of all, they do a lot of overtraining, and they usually have a calorie deficit diet because of not looking at their dietary intake properly. So they have low BMIs. This is one part of the triad. Second is because of that, there is a decrease in estrogen levels. So because of which they have menstrual irregularities, or sometimes even the periods can stop in such athletes, and they completely lose out on their bone density. So they become so osteoporotic that their bones are as poor as a 50 and a 60-year-old woman. This is called as a female athlete triad. So I guess kids, or especially girls who are into sports, they should definitely concentrate on their nutrition, their iron intake, vitamin D, calcium intake, and the overall calories they consume in a day.
Okay, ma'am.
There are studies from India which shows that REDS also exists in boys. There's a study in a Kabaddi group, the players on the national level, that REDS is also there in the boys. So it's very, very important to be careful, especially in the adolescent period, because it's the most rapid period of growth.
Yes, ma'am.
Ma'am, if the athlete is vegetarian, So would you advise a whey protein to a teenage athlete?
Whey protein, anyway, it is just apart from the milk, it's a
Supplement.
milk powder. Yeah. So
Yeah.
it doesn't have, Amrita, just correct me if I'm wrong, but I'm not aware of any, animal product in the whey.
No. So whey is, yeah, can be given, but I think if it's vegetarian, mostly I think we should also cover for vitamin B12 and other deficiencies. Those become very important.
Okay.
So basically, I don't know, parents, many times we get parents who say that मैं उसको cricket में डालूंगा तो वो fit होगा. So I always tell him, sports खेलने से fit नहीं होता. He has to be fit to play sports. So nutrition comes first and then the sports comes. So that has to be told to the parents. They always feel ये class में football class में डाला, इसमें डाला तो बच्चा fit हो जाएगा. It's never like this. He has to be fit first, then only he can play that particular sport. So I think that message is to be conveyed to all the parents because they start this football, cricket very early at 3-4 years. Also, they are putting children into that. But if their nutrition is not right, there's no way they're going to excel in the sports.
Correct. Fueling is a very important part of
Yes,
athletics.
absolutely. I think so. This session on sports nutrition was very important.
Preeti ma'am?
Yeah, absolutely. I totally agree with you that fueling is so important, and you have emphasized more and more on that, and that's excellent. And even hydration, I think those are very, very important points.
Can I add one thing?
Yes, yes.
Ma'am.
You can
Yeah,
add
so
much more.
we are talking about sports and like the early going for the gym or there is a constraint that we are not supposed to over stimulate the child, and there are strict punishments to even parents or teachers or the sports persons who pursue them beyond their limits. Your comments, Preeti ma'am.
I totally agree because there are studies which show that in fact participation in competitive sports increases aggression. So we have to be very careful about that. What kind of motivation are we doing, and we don't go to extremes? That is one. And also, that extreme weight loss, which you already saw what happened in the recent Olympic Games. It's quite horrifying as an adolescent pediatrician to think about that kind of weight loss and, how to lose weight even more and things like that. So these are some of the things which we have to be careful because at the end of the day, I think health is important, and health is not only physical, but mental and social and emotional as well. So we have to keep that, and also spiritual. So I think we should keep that in mind when children are pursuing sports.
Yeah, thank you.
One question in chat box: should adults and inspires need any oral supplements like vitamin B12, vitamin D, and any other
Sports
things?
sports है अमोल ते. Should adolescent in sports require
Yeah,
any?
sports only. Yes.
Regular supplementation is required of vitamin D and iron, but then we can keep checking their blood levels every 6 monthly. And if they can take in better quantity in the diet, then they don't require regular supplementation as such. But monitoring is very important. Like if the performance of the child is not improving, the child is becoming, irritable or showing signs of occult anemia, definitely the supplementation will be required.
Yes.
Thank you.
Thank you, Madhusri madam.
Thank you.
Yes. Role of from Dr. Jayashree Sabnis, role of meditation in anxiety disorder. Niti ma'am.
Yeah, today we are speaking about OCD, but when it comes to anxiety disorder also, there is a role of meditation in it. Seeing to it that it is not a repetitive negative thought which has been coming in your mind and leading to anxiety. Because in meditation, it is said that you're supposed to reduce the number of thoughts. And if your thoughts are clogged with negativity, and if you keep on meditating on those negative thoughts, the negativity increases. So once it settles down a little bit, then definitely there is a big role of meditation.
Okay. Thank you. Ashok sir, anything to add?
I think अमोल बहुत अच्छा सेशन है और ये स्पोर्ट्स पे तो एक एक्सक्लूसिव सेशन ही होना चाहिए.
Right.
That should include we doctors also. We had in our conference डॉक्टर A.K. रावत ने पूरा स्पोर्ट्स पे बोला था। तो एक सेशन तो जरूर, जैसे एडोलेसेंस कॉन्फ्रेंस है, हम लोग हमारे लिए तो कुछ बात ही नहीं करते। न्यूट्रिशन इन डॉक्टर्स, हाउ मच टू ईट, व्हाट टू ईट, हाउ टू टेक प्रोटीन्स, हमारा मेनू कितना खराब होता है कॉन्फ्रेंसेस में। वी शुड वर्क ऑन दैट।
बैंक्वेट भी कैंसिल कर देंगे फिर कुछ थोड़े दिनों में।
बैंक्वेट में ऐसा राशन करना पड़ेगा।
चलेगा। Yes,
Are there any more questions?
I think
Dr. Tanvi has asked to,
yes.
I'd also like to mention quality of sleep for any adolescent training about after working out.
Quality of sleep, adolescents are recommended to have at least 10 to 12 hours of sleep anyways, which is very difficult for them. That is a recommendation. But definitely sleep will help in recovery, because when the muscles are tired and when you do training, you need adequate sleep. It will definitely help in improving your performance. And a child who hasn't slept well before a match or hasn't slept well because of after training, definitely is going to affect his performance.
Yes.
I think we've done. Thank you. Thanks a lot, ma'am. That was really a very interesting topic and everyone has enjoyed it. Thank you, Dr. Amol sir. And I have declared now that the webinar has ended now.
Thank you. Rushali ma'am, for moderating this session. Thank you all for joining. Wonderful session of this two different topics. One on OCD by Dr. Niti ma'am and one on sport nutrition by Dr. Amol ma'am. So thank you both the speakers, moderator Dr. Rushali, and thank you all, Dr. Preeti Galgali ma'am, Dr. Amruta Shirkar ma'am, Dr. Ashok Mehta sir, Executive Board Member of Indian Academy of Pediatrics for the year 2024, and all the delegates. Thank you.